Hello, it's Amit Pawa here, and this is one part of the pro-con debate. I was asked at ESRA2025 this year in Oslo, Norway, to talk about mixing local anaesthetics, and I was the pro part of that pro-con debate, and I was debating against Dr Morné Wolmarans, a good friend and a colleague of mine, who, let's say, took a slightly less scientific approach when it came to taking me apart. But in the interest of good humour, I'm going to just put my part of the debate up. Now, remember, this is meant to be light-hearted fun. This is part of a pro-con balanced debate, and this is just a way of presenting some of the reasons why you might want to mix local anaesthetics. I don't want people to come at me. This is just some light-hearted fun. So my usual disclosures, but most importantly, I actually do mix local anaesthetics. And in order to win the debate, all I needed to do, I didn't need to convince people that they needed to mix local anaesthetics. I just needed to demonstrate that it's actually okay to mix local anaesthetics. Now, this is an AI image generated of Morné with his side of the argument. He thinks that mixing is madness because clearly not everybody agrees with me. It does cause some controversy. People are passionate about it. But the truth is, you know what, it's okay to mix local anaesthetics. And I'm hoping that during the course of this short talk, I'll be able to explain to you why. Now, I have been mixing local anaesthetics for more than 20 years. I've used it for awake upper limb surgery, awake lower limb surgery, and awake breast surgery. I think it's okay to mix local anaesthetics. Now, I know what you're thinking. You're all thinking, show me the evidence. But listen, I'm not going to tell you that mixing local anaesthetic is better. I'm not even going to tell you that mixing local anaesthetic is safer. I won't tell you that you need to mix. Just simply being pragmatic, I'm going to tell you that it's okay to mix local anaesthetics. Now, as we all know, too much of one thing is no good thing. For example, too many Mornés, or realistically, what I really wanted to say is, look, when we're giving a general anaesthetic, we don't give all of one drug. We often give a mixture or a cocktail of medications. So why should regional anaesthesia be any different? Now, how do we mix local anaesthetics? Well, we might mix local anaesthetics with adjuncts or adjuvants or additives within a syringe. So dexamethasone, epinephrine, clonidine with local anaesthetic. That's one type of mixing. We might put lidocaine to the skin and then using another local anaesthetic for the block. So in theory, that is kind of mixing in the same patient. But most often, people will do a proximal block with a short-acting local anaesthetic, such as lidocaine or mepivacaine, and distal blocks with long-acting local anaesthetic. Now, whilst you're not mixing at the same site, you're still mixing in the patient. Or you could put two local anaesthetic or adjunct drugs in different syringes and put them in the same syringe. So you might do an interscaling brachial block with lidocaine in one syringe, and then with a needle in the same place, put another syringe with some bupivacaine. Or what most people draw some objection to is mixing local anaesthetics within the same syringe and putting it in the same location. So these are all examples of mixing local anaesthetic. But people have been doing it for so long, so it looks like it's okay to mix, isn't it? Well, before we get too carried away, I want to tell you when I think you don't need to mix local anaesthetic. So if you want the block to last as long as possible, or if you're doing it as an analgesic block, so a general anaesthetic plus a nerve block, I don't think there's any value in mixing there. If you're using ropivacaine, for a few reasons that we'll reveal later, but certainly ropivacaine seems to work fast enough, I don't think you need to mix when you're using it. If you're doing a short operation with minimal post-operative pain, then I think lidocaine and mepivacaine or prilocaine is probably sufficient. You don't need to mix local anaesthetics there. If you've got a block room and plenty of time to put your blocks in ahead of surgery, I don't think you need to mix. Now, this is a little joke here because one of my colleagues, Bob Fonnecotter, is married to a pharmacist and he's vehemently against blocking local anaesthetics. But no, if you're using large volumes of local anaesthetic, such as those people who are still using 30 cc's or 30 mils of local anaesthetic in the interscaling region, then I don't think you do need to mix local anaesthetic. Now, the people that mix, what do they dream of? Well, they dream of having a solution with a fast onset like lidocaine, but a solution that produces a dense block with 0.5% bupivacaine and 2% lidocaine with epinephrine, which are the commonest used agents. But also, they want a Goldilocks block duration. So the block that doesn't last too long, too short, but just the right amount of time. So mixing local anaesthetic is not a compromise. it's a strategy. So, why do I mix local anaesthetic? Well, I really want to have fast onset or high turnover lists, and I don't have access to a block room. I generally have only bupivacaine or levobupivacaine and the short-acting stuff. I don't have ropivacaine regularly accessible. And often I want an intermediate block duration. I don't want a short block duration. I don't want a 30-hour block duration. I want somewhere in between. And also, if I am using paradoxically large volumes of local anaesthetics, such as when I'm performing a weight breast surgery, I want the lidocaine component to allow me to have a higher dose of local anaesthetics. If I was to draw up 60 mils of 0.5% bupivacaine, for example, or 0.25% bupivacaine, I may not have enough volume, but also the density of block. So I like the fact that I can mix. I believe it makes a difference for me. So I think it's okay to mix local anaesthetics. Now, I've talked about this intermediate duration block. Why might we want an intermediate duration block? Well, here are a couple of papers, the QR codes will take you to them, where actually they reveal that patients, they don't like having long-lasting numb extremities, and they don't like that long-lasting lack of control. In fact, they have a fear of paralysis or nerve damage, and the longer that limb is numb, the more nervous they get. So actually, have a read of these papers. They're really quite interesting patient perspectives, so something to bear in mind. So, if you desire quick onset and anesthesia that lasts longer than lidocaine, but not as long as bupivacaine by itself, that's why you might want an intermediate duration for a block, and that is why mixing may have a role. Now, many of you will say, why not just use bupivacaine and wait for the block to cook? Sounds sensible, but actually in the UK we have anaesthetic rooms where we might site the block, and we have surgeons waiting in the operating room or the operating theatre waiting to start operating. It's not always practical to start early or to delay the list whilst waiting for the block to cook. We often get pressure from the team that are working because they don't want to leave the hospital late, and from managers to get through the cases. And actually, if you can save minutes on a high turnover operating list, these can all add up, and you can save up to an hour or more. So actually there is benefit in doing something to speed up the whole process. Now, there are a whole host of reasons that people say we shouldn't mix. And this paper, the QR code will take you to the paper, is quite a powerful paper with a lot of anti-mixing sentiments and a lot of evidence and explanations as to why we shouldn't mix. And they mentioned the fact that adjuncts are unlicensed, such as perineural dexamethasone, which many of us are using. They talk about the fact that we're creating a solution that has a pharmaceutical compatibility that we haven't proven, despite the fact we've used it for many years. They do talk about the risks of precipitation and crystallization, the fact that recommendations on dosing are lacking, and that some additives and preservatives can cause neurotoxicity. And they also comment on the fact that these admixtures of local anaesthetics are off-label, and we produce a solution with a variable pH, and pH can of course affect the amount of unionized local anaesthetic that is around to have its effect. And they also talk about the fact that there is a lack of evidence of benefit. However, this practice has been going on since the 1960s at least, if not before, and still appears safe. So does that mean that it's okay to mix local anaesthetic? Well, I would say it does. I do want to spend a little bit of time looking at crystallization, however, because this is an interesting paper where they took 7 local anaesthetics and mixed them together, plus or minus some adjuvants, and they assessed them for crystallization via light microscopy over 60 minutes, and they came up with a grade of crystallization. And what they found was that ropivacaine was worse than bupivacaine, and that the crystallization increases over 60 minutes. And here's an example. This was included in the paper. You can see these crystals form outside the body but under light microscopy. You can see here his bupivacaine with lidocaine and clonidine, and all the other pictures they included ropivacaine as the long-acting medication. But look at the worst one in the corner over here. This is ropivacaine, lidocaine and bicarbonate. That was associated with the most crystallization. So my interpretation of that study is don't mix with ropivacaine, don't use adjuvants, use your medication as soon as you've mixed it. Bicarbonate does seem bad. I don't use it, but it has been used clinically without issue, especially in obstetrics. So despite all of that, I still think it looks like it's okay to mix local anaesthetics. What about the evidence? Now, when I look at the evidence, what I hope to see is that they use ultrasound guidance for their blocks. I hope to see safe technical performance of blocks. I want to see sensible use of local anaesthetic volumes with pooled comparisons of the same blocks, and I expect that the time for block onset would be longer for the long-lasting local anaesthetic, shorter or quicker for the short-acting local anaesthetic, and mixed in between for the mixed local anaesthetic. That's what I expect. I would expect that the pure long-acting local anaesthetic would last the longest, and the short-acting local anaesthetic by itself would last the least amount of time, have the shortest duration. And when you create a mix, I expect it to be in the middle. We don't expect it to be as long as the long-lasting local anaesthetic. So let's have a look at some studies. This one is from 2025. It's a systematic review and meta-analysis of 19 trials, over 1,000 patients, and the risk of bias assessment overall looks pretty good. There's lots of green over there. They came up with the fact that mixed local anaesthetics, so mixing two drugs, reduced the onset time to surgical block, is what we expect to see, what I'd hope to see, by about 8.4 minutes. But it did reduce the block duration. Again, not a surprise, but interestingly, the mixed local anaesthetic, despite reducing the block duration, did not reduce the analgesic duration. So that's good. And actually, if you look specifically at this paper, in this plot over here, you can see that the biggest difference was actually for lower limb blocks. This was a heterogeneous study, upper limb, lower limb and trunk, but the biggest difference was for mixtures being beneficial was for lower limb blocks. So I think it's okay to mix local anaesthetics. What about this trial here? Now this is from 2024, another systematic review and meta-analysis, 10 trials, less patients, 516 patients. That risk of bias diagram doesn't look quite as good here. They said that mixed local anaesthetic may have no effect on block onset. Not so great, but there was a heterogeneous population and a very low level of certainty. They said mixed local anaesthetic may reduce block duration. Again, not a surprise, but interestingly, again, despite the block duration being less with the mix, there were no differences in pain and opioid use at 24 hours. But again, 50% of the studies here had a moderate or high risk of bias. Not so great. So I still think it's okay to mix local anaesthetic. This study was from 2025. Another systematic review and meta-analysis, this time less trials, less patients. We again note that 43% of the studies had some or high risk of bias. They looked at the use of bupivacaine and lidocaine versus bupivacaine alone in brachial plexus blocks. They didn't see a difference in block onset. Not great. The mixed solution reduced block duration. Again, I'm not surprised by that. But their final statement was, the overall certainty of evidence is very low. These conclusions should be interpreted with caution. So I think on the basis of that, it's still okay to mix local anaesthetics. So the evidence doesn't look great, right? I would like to look at 3 RCTs specifically. So this one is often cited as evidence against mixing from my good friend Jeff Gadsden from 2011. They took 64 patients having shoulder arthroscopy and they did an interscalene brachial plexus block plus some variation of monitored anaesthesia care. They looked at mepivacaine versus bupivacaine versus a mix of both. And they looked at the onset of sensory block at the axillary nerve sensory distribution and found that it was similar in all groups, which is really interesting. They found that the motor block was lasted with bupivacaine, again not a surprise, mixed over mepivacaine. And they also found the analgesia duration was greater with bupivacaine than the mix and mepivacaine, again not a surprise. However, they used 30 mils or 30 cc's of local anaesthetic. That's a massive volume in the interscalene region, and I'm not surprised that they weren't able to show a difference in the speed of onset between those solutions, because you can put 30 mils of a long-acting local anaesthetic in there and it's going to work fast. But what that paper did show was if you take a short-acting local anaesthetic and a long-acting local anaesthetic and mix them together, you get an intermediate duration of action of that mix. So that kind of confirmed what we were expecting to see. So I think on the basis of that, it's okay to mix. Now, I wanted to look at this other paper. This was from 2024. This is in support of mixing. These were 63 patients having upper limb bone surgery. They had a supraclavicular block with sedation. Now, they either had 20 mils of lidocaine with epinephrine, or 20 mils of bupivacaine, or 20 mils of a mix of lidocaine with epinephrine and bupivacaine. Now, what they found was the speed of the onset of the mix was the same as the speed of the onset as lidocaine and epinephrine. So actually, The mix worked as fast as lidocaine with epinephrine at about 16 minutes, but it was definitely faster than bupivacaine alone, which was 21 minutes. So you can see potentially there's about 5 minutes difference in speed of onset. When they looked at the proportion of patients who had a complete block at 40 minutes, bupivacaine patients only had a 48% chance of having a complete block, whereas 95% of the mixed patients at 40 minutes had a complete block. So I think when you look at this study, when they put 20 mils of local anaesthetic at the supraclavicular brachial plexus, a mix produces a faster and more complete block compared with bupivacaine. But I do want to bring your attention to the fact that actually they performed intra-cluster injections, so a slightly more aggressive technique than I would like to do. But they definitely showed that a mix produces a longer duration than lidocaine and epinephrine alone, again confirming what we expect. So I think it's okay to mix. And then finally, I want to look at this study over here. This is from 2024, and it tells us that bupivacaine lasts longer and has a slower onset than the mix, and nothing new. They took 40 patients who had a fracture of the forearm, wrist, or hand, and they did an infraclavicular brachial plexus block with monitored anaesthesia care. They took 35 mils, and the mix was bupivacaine, 0.25% bupivacaine with 1% lidocaine versus 0.5% bupivacaine alone. Both of these solutions had epinephrine and dexamethasone as part of them. When they looked at the motor block, bupivacaine had a 28-hour motor block versus a mix, which was 18.9, not a surprise. Sensory block with bupivacaine, 29.3 versus the mix. Again, none of these are surprising bits of information. But interestingly, when you look at the onset time, with bupivacaine, the denser solution, 0.5%, it was 35 minutes versus the mix, which was 20 minutes. Now, again, this is compelling. This shows us that there's benefit with mixing with regards to onset time. There was no difference in rebound pain. Again, useful here. So despite using 30 mils of a mix with a final solution of 0.125% bupivacaine and 0.5% lidocaine, the mix in this study produced a faster onset compared with bupivacaine. So again, that may be a volume effect. So I think it's okay to mix local anaesthetics. Now, when we summarise the evidence, what do we see? We see that a lot of the data is heterogeneous. They use a combination of nerve stimulation and ultrasound. They have varying testing and timing protocols, so how they define block onset varies between different studies. Some of the papers combine upper limb, low limb, and trunk blocks all together. They've got variable doses, volumes, concentrations, and techniques, and many studies, as we've demonstrated, have moderate to high risk of bias. So having looked at the evidence, I don't think it's that great, and I would say it's okay to mix local anaesthetics. But where people get stuck or nervous is working out what the maximum safe dose of local anaesthetic to administer is, either just in isolation, but certainly when mixing local anaesthetics. Now, if you look back to this paper from 1981, which is a study on rodents, they worked out that mixtures of local anaesthetics are less convulsant or lethal than the individual drugs by themselves. And they also decided or determined from the data that toxicity of local anaesthetic is likely to be additive and not synergistic. So their conclusion from there, and that's a sensible piece of advice, is do not exceed 100% of the combined maximum doses of local anaesthetic, i.e. for using two agents, don't use 100% of the dose of each agent. Use maybe 50% of one agent's dose and 50% of the other agent's dose. Thereby you're not exceeding 100% of the combined maximum doses. So how can you work that out easily? Well, there are a couple of different ways that you can do this apart from just back of envelope calculation. This study in anesthesia came up with this nomogram where you can plot the patient's body weight, the agent you want to use, and draw a line between them, and it will tell you the maximum volume you can use. That's one option. The other thing you could do is have a look at this special app that I'd seen. It's called Safe Local. The QR code will take you to the Apple version of that app. Actually, you can plumb in what medication you want to use, the concentrations that you're going to use of each of those medications. Then you can add in the patient's weight. Once you've added in the patient's weight, you can select any particular comorbidities they may or may not have, and then it will tell you the maximum dose per local anaesthetic. and you can use a proportion of those doses, and it will tell you how much you've got left over to give for yourself as a block or to the surgeon. So I think this is quite a clever thing to use. Now, one final word on mixing. My good friend Ki Jin Chin.
Vincent Chan taught us to do mixing. It is the Toronto Western
Okay, this is a
tradition
mic.
and
Let
culture.
me just get this.
Yeah.
I can't
Okay,
do a
okay.
mic drop. Yeah.
We both learned from Vincent
So-
Chan.
Mic
Yeah,
drop.
yeah, yeah, yeah.
Vincent
Mixing
Chan,
local
Vincent
anesthetic
Chan,
is okay.
Anahi Prelas, Ricky Bro, all do 2% lidocaine, 0.5% bupivacaine, and so I do it.
So I would say, if it's good enough for Ki Jin, it's good enough for me. Okay, listen, to conclude, you don't have to mix local anaesthetics, but if you need to speed the onset by 8 to 15 minutes and you're using sensible, safe volumes of local anaesthetic, if you design an intermediate block duration that doesn't last for 24, 25, 26 hours, and if you're performing lower extremity blocks such as femoral or sciatic nerve blocks, I think it's okay to mix local anaesthetics. All that you need to decide is whether it is okay to mix local anaesthetics. Morné and I are good friends, and I think it's worthwhile knowing that you should vote yes for mixing. Thank you very much. I hope you enjoyed one sneak preview of one half of that pro-con debate from my ESRA 2025 talk. Many thanks.